Friends, selecting the right patient for multifocal IOLs is so important. We say that the three C's are important to check. That's the calculation, that's the candidacy, as well as the counseling part for multifocal IOL evaluation. Now, in this video, I'm going to give you at a glance a quick overview of what you need to check to determine the candidacy of this patient for multifocal IOLs. Now, here I have categorized into four broad headings. That's the biometry. What do you need to see in the biometry? Cornea and hyoid aberrations, pupil, as well as the ocular. Now, under the biometry section, what you need to see is the axial length. The two-eye axial length difference should be less than 0.3 millimeters. And if it is a short axial length, axial hyperopia, then you could also take it as a cutoff value of zero point 0.2 millimeters. You should also see the standard deviation of the axial length, and the standard deviation of axial length in the optical biometry machines should be less than 0.05 millimeters. If it is more, you should recheck. Now, coming to the topography here, you should look for a symmetric bow tie. This was my first video in the YouTube channel. And here I actually provide you some of the basic structures of how the corneal map can look like. If you have a topography, look for a bow tie, symmetric bow tie. This is normal, but all other forms are actually not very normal. This is the skewed radial axis. This is actually, an asymmetry between inferior and superior. This too. So look for this kind of shapes which may not actually make the candidate suitable for multifocal IOL implantation. Now, coming to the K readings, now this is often missed. Look at the standard deviation of the axis, not just the standard deviation of the axial length, but the standard deviation of the axis. Let me show you this picture over here from the optical biometry machine. This is the Lensstar. It also gives you the standard deviation, but you have to activate it in the settings. Now, these are your standard deviations over here, this column. For the right eye, this column. For the left eye, this column. These are the standard deviations that you need to see. For example, you can see the standard deviation here is very high, 6.5 degrees, but it could be because there is a very low astigmatism. But you should always see the standard deviation, which is very high, 6.5 degrees. It could be because that there is some amount of dry eyes that is actually, leading to some erratic measurements. If you are looking into the corneal reading, look for an average K value between 41 to 47 diopters. Now, coming to the cornea part, look for the endothelial cell count. If it is more than 2500, then that cornea is very healthy for multifocal IOL implantation. And you could also look into the hexagonality and the coefficient of variation, but also keep an eye on the thickness. This red, the letters actually indicate that this is something that you should not be missing out. Now, in the cornea, also coming to the cornea, you should also see the higher order aberrations of the cornea. If it is less than zero point 0.5 microns, you're good to go. But also important is to see the individual aberration values like the coma, the trefoil, and the spherical aberration. Because these are the three most important, aberrations that can actually lead to challenges of vision, dysphotopsia post multifocal IOL implantation, and this should be less than zero point 0.3 microns, preferably within zero point 0.2 microns. Now, angle kappa, angle alpha, angle kappa is the difference between the visual axis and the pupillary axis. Likewise, angle alpha is the difference between visual axis and the optical axis. Now, if you have a optical biometry machine, it will not give you the angle kappa, but it will give you some corresponding values of chord length, and that is actually similar to angle kappa. So the in the IOLMaster, you will get the chord length. The chord length value should be less than zero point 0.5 millimeters. And if your machine gives you an angle kappa in degrees like the OpScan, it should be less than 5 degrees. Now, if you go into the pupil section, the next is the pupil section. In the pupil, you should look into the pupil size. Now, if the two eye pupil size differs by less than 1 millimeter, chances are that this is a physiologic anisocoria. But if the two eye pupil size is more than 1 millimeter, chances are that could be a pathological anisocoria. So you may want to rule out those patients from optical biometry, and this is from IOL implantation. And this again you will find in the optical biometry page. You will see the two eye pupillary size differences over here. Now, Coming back again to looking into the direct reflex and consensual reflex is important. Throw the torchlight on the left eye, look for the direct reflex, and also look for the consensual reflex in the other eye, and repeat the test again. You should look for that there is no relative apparent pupillary defect, also focusing reflex is there, and that there is no Argel Robertson pupil. Now, coming to the ocular structure over here, dry eye test that is important. Subjective symptoms, look for the subjective symptoms that there is no irritation in the eye, no redness in the eye. And also to the dry eye test, shimmer test is often done, which actually gives you an understanding about the aqueous production, which should be more than 15 millimeters without anesthesia. Now, tear film breakup time is one test that you could do. You could also do a fluorescence staining if you don't have interferometry. So, tear film breakup time should be more than 14 seconds. Most practices will not have the osmolarity test, but if you have rarely, then you can actually look for values of less than 300. TS meniscus height is something that you can actually see in the under the slit lamp, and the TS meniscus height over here should be a zero point 0.3 millimeters, should be zero point 0.3 millimeters, and normal IOP. And these are actually some of the things that I would request you to see to evaluate whether this patient is a candidate for multifocal IOL so far as the anterior segment is concerned. Thank you very much.